afternoon, and welcome to Health Matters, a weekly conversation with experts about the medical issues that matter most to you and your family. During this unprecedented global crisis, we've been witnessing an overwhelming amount of misinformation about COVID-19 and its origins. Our objective is to bring you behind the scenes with the experts on the front lines. They are caring for our community and working to find a cure and a vaccine. We ask you to please use the chat box to ask your questions for our two experts. Today, we're joined by Dr. Makeda Semret and Dr. Marina Klein. Both of these exceptional women are clinicians, researchers, McGill professors in infectious disease.
I think one of the things that has surprised us about this infection, and Makeda alluded to it, that on one hand can seem to be quite mild for a large number of people, but on the other hand can have very severe outcomes for others. And who is at risk for those is not entirely understood. There's definitely some clear risk factors like age and other chronic illnesses and conditions that predispose people to being more sick. But and those people who develop severe symptoms often have a very long course of recovery. And in some instances, it can be months even where there's residual difficulty with breathing and deconditioning and other problems. But we don't fully understand why, for some people, it seems to attack various different organs in such a severe way, and what, if any, long-term consequences they may have because of that. Certainly for our health systems, we're already seeing the short-term impacts in terms of it being so pivoted to focus on COVID that we are unable to, continue our full activities otherwise. And people who are having other major conditions, cancer, heart disease, and even elective surgeries that have been put on hold due to our inability to address everyone's needs all at once during this period. But it may also have some beneficial effects in the long term about how we address health going forward. And obviously, our economies will suffer and are suffering. And like everything, we have opportunities, I think, to think about how we can change and do things better in going forward.
But from a research perspective, it certainly also had an impact in the duration of time it takes for medication or vaccines to come on the market. But we'll talk about that a little later on. Makeda, I understand that you've actually developed the MUHC treatment plan for COVID-19 and our patients. Can you tell us a little bit about this treatment plan?
Yes, so I mean, even before COVID, the MUHC had what's called an antimicrobial stewardship program. So this is a program that's run by an infectious disease specialist, so me in this case, but is composed of several members of our group, as well as pharmacists. So for a lot of the infectious entities, we get together and try to decide on what is the optimal therapeutic regimen. So what is the right, and our goal, our objective is really to say, give patients with infections or suspected infections the right drug at the right time and for the right duration. So we've already been working quite solidly in that from that perspective for the last couple of years. So when COVID came along, it was basically striking the same group plus a few additional experts. And before we even had the very first patient admitted in our hospital, we had to, we decided to get together and go through all the available data that was out there back in March or early March, late February. So we had to go through the data coming out of China, out of Italy, etc. So the places that had cases until then. And between all of us, we argued and debated and came up with a consensus as to what made the most sense with the data that we had, and immediately after that devised the guidelines, disseminated across the institution, and put it up. And the way we communicate is we have a website, so we disseminated through the website. So by the time the first patient came into the MUHC, we knew exactly what to do, or the physician, the frontline worker in the emergency room had a document that was visible on a website and therefore knew what to do. And it also has the advantage that it sort of harmonizes practice across the institution. Now, the decision we also made very early on is not only to have a harmonized document that everybody could refer to, but it was also to say the standard of care for the MUHC will be excellent supportive care. meaning, you know, we're not underestimating the importance of nursing, of providing oxygen if it's needed, of monitoring kidney function, liver function, cardiac function. All of those things matter for the reasons that Marina mentioned earlier. So we weren't going to blindly start throwing different antivirals in the hopes that something would work. We were going to be evidence-driven, and we were going to do no harm by potentially giving you know, antivirals that could have deleterious effects. And further, we were going to offer every patient that was admitted here the chance of participating in a clinical trial. And that participation in a clinical trial was actually part of our standard of care. So this is a decision we came to, and Marina is part of our group very early on. So, you know, it says so at the very top of our guidelines that every patient should be approached, and that we really believe is the best way to give, you know, potentially optimal treatment.
But Marina, who decides what medication which patient gets, and how is that offered to them?
So it really stems from exactly what Makeda said. We decided as a group that this would be protocolized to the point where we would not suggest the use of any medication that didn't have sufficient evidence behind it to be confident that it would have a benefit. And as you can imagine, that's a moving target during this time. And we've struggled with that because the good thing about this document, it's a live document and it's regularly reviewed, updated, and we have recurring meetings to make sure, are we still sure that this is the best recommendation? Oh, this new evidence has come out. Should we modify our guidelines? And they have been modified quite significantly over the course, where at the beginning, we actually considered, using some of the drugs that have been in the news a lot, which include hydroxychloroquine, but rapidly, with the emergence of evidence, quickly moved away from that and to offering clinical trials. And then these clinical trials, which are really key to making us have good evidence, providing us with good evidence to know what to do, need to be large. They need to be well done. They need to be done on a worldwide scale. And they are several, mostly led through a WHO initiative, something called the Solidarity Trial, which many of you may have heard about in the news, which is, comparing different potential treatments. So when we start this process, we have to take something off the shelf. We don't have time to develop a new drug. We have to say, okay, given everything we know about these viruses, everything we know about the existing types of treatments out there, what is most likely to have a benefit? And we could test it right away without having to go through all the early stages of making sure it can be used in humans, it's safe, etc. We know its profile from other studies. And so that's where things started. And what's really been amazing is how quickly a worldwide effort has come together to test various promising therapies and get answers in real time, almost within months, that can allow us to change the way we do practice. And so we've already put things on and taken them off. We've now recently added, for example, one of the studies has shown the first treatment that seems to definitively have improvements in terms of outcomes is something we've used for many, many years. It's called dexamethasone. It's a corticosteroid that's used to treat inflammatory disorders. Part of the COVID-19 serious effects is often related to overwhelming inflammation in the immune system that the virus triggers, and this drug seems to help suppress that and gets people out symptom-free sooner and has lower mortality, less death. So that's now been integrated into our guidelines. So you can see how it's sort of like an iterative process. We are constantly looking at evidence, constantly changing things, trying to provide best care for people in real time.
So you've told us about a cortisone that seems to be having a positive impact on our patients. Makeda, can you tell us about some of the other medications that seem to have a positive effect?
So actually, cortisone is the one that has had the best effect so far. So from the data that we're seeing around the world, some of the antivirals that have been tried, there's already a couple that have been removed from future studies. So they are shown not to be better than supportive care alone. There is, the data out of the US showing a positive effect of remdesivir. That's the next drug that we will be trying through one of our trials here. We don't think it's going to be as miraculous as the Americans are making it out to look. And certainly, you know, the fact that this corticosteroid, the dexamethasone, is available, I think, is really an important finding, because the benefit of this drug is going to be on the most severely ill, which are really the focus of a lot of our clinical trials. So the fact that we're going to be able to reduce the mortality associated with severe disease is already very reassuring. Now, remdesivir will be added onto that as one of the trials we're going to, as one of the antivirals we're going to be trying. I mean, our standard of care is really, as I said earlier, supportive and no random antivirals unless the patient is part of a clinical trial. And I think, and in terms of clinical trials, we're looking at two different strategies, where instead of, you know, agreeing to participate in a gazillion trials, looking all at different molecules, we have really, as a group, decided we'll have two major clinical trials. One is looking at different antivirals, and that's the Canadian CATCO trial, which is a branch of the WHO Solidarity Trial, where we're assessing different antivirals. The other arm, the other avenue, is looking at the benefit of plasma on those patients. So those are the two things that we're offering.
I think we have pause on plasma, because that's an important trial,
sure.
Of which we are participating, I believe, with 6 other hospitals in this province. Marina, can you tell us what exactly is this plasma trial, and what impact are you seeing so far?
So what's really interesting is that we're starting to learn. There's quite a lot of controversy still in the news often, but we're starting to learn that almost everybody who gets exposed to COVID-19 forms some antibodies as a protective response to this illness. It seems that these antibodies are developed in people particularly who have severe illness, and that those antibodies in those people are what we call neutralizing antibodies. These are antibodies that are actually able to neutralize the virus, kill the virus, and then could help actually improve the clinical outcomes for people. So, and there's some people who seem to make these antibodies in abundance, kind of supercharged immune systems. And so this plasma study is really building on a whole history of immune treatments for other viral diseases in the past, as far back as the 1918 pandemic influenza. So this is an old idea, but one that, you know, bears a lot of fruit in the past, and we think holds promise now. And so this trial is basically organized, probably principally starting in Quebec, but now it's across country. Hema-Quebec in Quebec is the one that's doing the plasma collection, and concentrating these antibodies in the plasma, and that plasma is then given to people who are suffering from COVID-19, who have pneumonia from COVID-19 or oxygen needs. Makeda is actually the lead investigator at our site for that study, so she can perhaps provide some details on, you know, how it's been running and going. But we think that this avenue in general is one that's really promising.
So Makeda, if I think that I am a super carrier of antibodies, what do I do, and how do I find out? How do I donate and participate in this?
Yeah, well, the way you would be, so you would be tagged, so you would be identified by Hema-Quebec, actually. You wouldn't be able to know it. So Hema-Quebec coordinates with the Public Health Institute of Quebec to identify who got sick and who's, you know, of a certain age, as well as the dates of your infection. So if you're more than 4 weeks after your convalescence, after you've recovered from your infection, you might get called by Hema-Quebec to come and donate blood. So Hema-Quebec, as Marina mentioned, is trying to target the super donors. So they do a blood test, a simple blood test, to check their antibody levels. I mean, these are not tests that are yet routinely available in diagnostic laboratories around the province, but they are available through Hema-Quebec. And then they select those donors that have very high titers, and then and bleed them repeatedly for plasma. And then they purify the sample. Obviously, they're screening these patients to make sure these are not patients that are carrying hepatitis or any of the other viruses that could be transmissible through blood. and then they store these samples for us. And when we need it, if we have a patient that's a candidate for the study and has agreed to participate, we call them up and we get the plasma delivered to our doorstep, and we then administer the patient, we transfuse the plasma and collect data after that.
So how long is it going to take before we can say whether this was a success or a failure in terms of a treatment plan?
Well,
let's go ahead. Challenge now, which is it's a good challenge and a bad challenge. And to give you a sense, the first study we talked about with the antivirals, the CATCO study, which is, we recruited 50 patients at the MUHC alone. That's 25% of the total Canadian participation in that trial. That's because we had a very good program to do the recruitment, very engaged principal investigator, all those reasons. But it was also because Quebec was an epicenter for this epidemic. And so we had a lot of people who were sick. Well, fortunately, that's no longer the case. So we're seeing, we flattened the curve, as they say. And now, as you know, there's pretty much nobody admitted to the MUHC with COVID-19 anymore. So it becomes challenging to conduct clinical trials because we no longer have patients who can be enrolled.
How many patients do we have at the MUHC? How many patients do we have at the MUHC right now?
Right now, it's about 20.
About 20 or less.
Yeah.
And at the height of the pandemic for Montreal, how many patients did we have at the MUHC?
Well, we had 120 patients admitted, I think.
Sorry?
Over 120.
Definitely over 120, and that was just on the wards alone. I think we also had a lot of patients in the MUHC, in the ICU, and so between the General and the Royal Victoria, I think there were times when we were probably close to 200 patients, 180 to 200 patients, but don't quote me on that.
That's significant.
Yeah.
So we went through obviously months of confinement, which was extremely difficult for many of us. Is there any way, and I'll turn this to you, Makeda, do you think that we can possibly avoid a second wave of this pandemic?
The million-dollar question. So, yeah, I mean, the short answer is I don't think so. I think it's very unlikely we'll avoid a second wave, but it all depends on what we call a wave. I don't think, or I hope we don't have like a sharp, big tsunami of a wave, right? But we certainly will have riplets and moderate or flatter waves for some time to come. As long as there are parts of the world that are still struggling, and including the countries south of us, that are struggling with large numbers of cases, and people are eventually going to start traveling and are already, opening up, I just don't see how it's possible to avoid the virus from re-entering. I mean, first of all, it hasn't completely left us. I mean, there are still cases in Montreal as we speak, but I don't see how it will be possible to be protected from the entire world forever. This is just going to pop up in different parts of the world, different provinces, different settings, until a big portion of the population is immune, has either been vaccinated or has acquired immunity.
So we can't hide from this virus, if I understand your perspective on this.
No.
Marina, we had another outbreak in Brossard, and it was all in all the papers this morning. Some people are calling for the closure of bars and reduction of restaurants again. Should we be surprised when we have these outbreaks? I mean, is this part of our strategy now to avoid having any even small outbreaks?
Yeah, I think what we have to do is turn our attention now where there's small enough numbers in the community and that they can be managed like little fires, putting them out. We have to remember that we have to be able to identify those people very quickly and contact trace all the people they may have been exposed to, and then isolate those people and test them as quickly as possible. And there's this delay between when someone's exposed, develops symptoms, which is on the order of about 5 or 6 days. In a week's time, you can have a lot of additional contacts without knowing that you're infected. And so we're seeing very clearly south in the US how, especially among young people who gather much more often in large groups, that this can explode very quickly. So we have to keep our eye on this, and we have to have very aggressive public health measures in place to contact trace. And I think we're going to see, as Makeda said, different waves of infection, and we're going to have probably sectors that will close reopen. You know, it really seems that indoor gatherings of a certain number are where these big events, super spreader events occur. And those are identifiable, those are manageable. So we may have to accept that we're not going to be able to keep bars open to the extent that, you know, I understand the other side, the economic side, but there's a huge economic cost to letting COVID go on unchecked. So, and it'll rapidly spill into other parts of the community. So it's not as if you can contain it in, you know, a certain small population. So we're going to probably see these waves of closures and opening, and hopefully we can manage it so that most of our activities can continue, albeit with a very different look, face mask and plexiglass.
Yeah. You mentioned face masks. Quebec is considering making masks mandatory in all public places. Makeda, I'll turn this to you. How do you feel about that? Is that the right strategy? Is that necessary in terms of fighting this pandemic?
I think it's been shown in some parts of the world where it really did help, right? And you know, is it necessary? I think it is necessary while we're still in the period we're in. We've just you know, sort of opened up again, but we still have cases. So if we went about our life as we did pre-March of 2020, we could expect many more outbreaks, such as what happened in the bar. So I think masks are definitely a good initiative, a good thing to do for indoor spaces. And maybe not necessary if you're sitting in a picnic in a park, but for indoor, I mean, I didn't like masks before. I hated having to wear them. If I had to go into an isolation room, I found I was claustrophobic, but I must say I've gotten used to it, and now I don't feel safe walking into a store without wearing my mask. So I think it's something that we have that is easy to get used to, and that will show in the long term, it will be beneficial.
If I'm looking to buy a mask, Makeda, should I be looking for something in particular? Is a cotton or polyester good enough, or should everyone be running and getting the N95 mask?
No, so the N95 mask, I think, really should be limited very much to healthcare, and even within healthcare. I mean, we have again looked at all the literature and made the decision that only certain procedures, so only like, you know, certain medical procedures that will generate what we call aerosols, those are the only conditions under which we recommend N95 masks. I mean, N95 masks work well under those situations, but you have to be fit tested. You have to have, you know, otherwise you might as well have a surgical mask, because you're not actually well protected with an N95 mask if it's not exactly fitted to your face. They're very uncomfortable, very hard to breathe in. So people will touch it and remove it. And so will actually increase the risk if that's what you're trying to do. So I think the regular, either the surgical masks that are the commercially available, or in fact, even the cloth masks, you know, as long as it's a slightly tightly woven cloth, could do the trick. And really the idea being to protect others from you, right?
And it protects us as well from others, I take it.
Yeah. Yeah, to some extent, yes. You know, the visor is sort of the face shield, or the visor is what really protects droplets from coming to your face and potentially being absorbed through your eyes or your nose or mouth. And the mask is what protects others. Like, so this is sort of the simplistic way of remembering it.
But the more people wearing masks on both sides, then you actually reduce the risk one to the other. So I think that's the idea, is really to normalize it. It's a small price to pay, really. Of course, we would much rather be able to see each other. You know, I remember seeing a nurse on the ward once when she changed her mask, and I thought, oh, I never even, you know, saw your smile before. You really nice smile. So we miss, you know, that human contact. But it's really a relatively small price to pay, and it's really a generous thing to do if you think about it. Because you are protecting those people who, if they were to get this virus, would actually potentially have very bad effects from it.
So I turn to the audience. If you have any questions, please do continue to share them on the chat box, and so we can ask our two experts. Marina, I'm just going to ask you, it used to take millions of dollars and years to get a new drug on the market as standard of care. And now it seems that Health Canada and the FDA have drastically reduced that timeline. Now, is this a good thing, and is this here to stay? Are we transforming in the middle of this pandemic how we approve new medications?
Yeah, I think it's actually one of the really remarkable things that we've seen, not only the regulatory agencies like Health Canada and the FDA, but also how we're working with our ethics board, and particularly here at the MUHC. It's been a really collaborative effort trying to reduce all those steps that kind of slow down the process while not compromising patient safety. I think that's that balance that we have to have. And so, sort of akin to what happened early on in the HIV epidemic, where there was this real need to get drugs to people who were suffering fast. They really looked at the processes by which we could approve drugs more quickly. And this is being done again now. So I do think it will have a lasting impact. The flip side to all this, though, is that, everybody in the world thinks that they know what the next treatment is for COVID-19. And they put together a protocol, and then they submit it to the ethics board, or they submit it to review, and many of those probably have very little chance of actually having any benefit, and they clog up the system to some extent, which I think can be detrimental. And we're also seeing the publication of work in sort of like a preprints, which is not yet peer reviewed, which can have a real negative impact on how people perceive science and its value. So we have to constantly be vigilant about those things and call them out when they occur, and be very careful not to incorporate, as we've done, for example, in our guidelines, anything that isn't actually really well done, well validated, and scientifically solid. And so that tension is going on right now, but I think at the end of the day, we're going to have a much more nimble solution to dealing with getting drugs to market faster when they're needed. They still cost millions of dollars, though. The cost of development is not any less. Yeah.
Makeda, we heard from our experts 2 weeks ago that we should probably expect a vaccine or a few vaccines in probably a year to a year and a half. Do you think that it's likely that we can end this pandemic before then with a potential cure, for example?
So I think with a potential cure, what we'll do is we'll reduce mortality, and we'll potentially reduce or accelerate recovery of patients. We won't end new infections. We don't, with any of the therapeutic avenues, we can't prevent an infection. So at least I think we could say if a patient gets sick, we'll be able to better care for them and ensure that their chances of death are reduced, but only a vaccine will reduce new infections.
Yeah.
And only a vaccine or natural immunity will end this pandemic.
So Marina, I'm going to turn it to you. We've talked a lot about some of the drugs that are showing positive impact, but at this point in the pandemic, what keeps you up at night? What are you most concerned about?
Well, I'm taking a big, deep breath right now. I think it's kind of really nice that the kind of intensity, the craziness that all started when we were gearing up to expect that first case and putting all this stuff in place and putting, and then working through it, being on the wards, taking care of people, and that has now died down, and we have a chance to kind of step back and breathe a bit, which has been really a relief. I think a lot of us were, and still are, quite stressed, I think, because it takes its toll. And I do worry that we'll let our guard down, that we won't, it's so easy to walk out there and think, oh, it really feels like normal again. And unfortunately, it's not. And it really isn't. And when you don't see what we saw and how major impact this has for many people, it's hard to envision how it can get again. And I think that's my worry, is that we'll be back here again the end of August, early September, and then as flu season comes on, it'll just be much harder to manage. And then again, we'll have moved all of our efforts and resources back into taking care of people who are sick with COVID, which I think is avoidable. I think we have the tools to keep ourselves from, to get ourselves through till the point where we do have the vaccine and those better treatments. We just need to stick to our guns and do it. Yeah.
And how about you, Makeda? What keeps you up at night?
Yeah, partly as Marina said, I think this feels the last 2 weeks or so have felt like a big sigh of relief. We have we're beginning to work. I mean, I think last weekend was the first weekend that I didn't come into work since mid-March, so we're beginning to feel like maybe we get a bit of a break. I think my biggest worry is the collateral damage we spoke about, not so much the economic collateral damage, but the collateral damage that's happening around the world related to COVID. So, a lot of the low resource countries, such as my country of origin, Ethiopia, they're doing all of the lockdown measures and having to apply kind of similar restrictions as we have done for 3 months, but with little testing ability, with little ability to actually quarantine patients that have tested positive, and completely unable to afford the cost of containing the virus. So I'm quite privy to all of that data because I am professionally active there, and I hear the discussions, and I'm on the advisory groups for the ministry, etc. So I see how difficult it is also for poorer countries. I mean, fortunately, or in a sense, maybe they won't be impacted because their populations are so young and they don't have as many high-risk patients. But the impact that it's going to have on the world and the instability that might create as a reaction to this, if suddenly these countries become completely impoverished and they go through an economic collapse, they're already usually on the brink of famine. What is that going to mean for the rest of the world? So I think, this is very close to home in my case.
And building on that too, I think you're very right, Makeda. It's worldwide, but the geopolitics here are very frightening, and we only have to look south of us to see that this could play out in very difficult and negative ways. And we're very fortunate to live in a country that where science is respected, decisions are made with science at the core, and people are very willing to sacrifice in order to make sure that we can do this collectively. But we're going to be in a very difficult time period coming through, I think.
So on that, looking down south, Marina, many of our audience today have homes in Florida or other states. When do you think the borders should be opening? I mean, are we going to be waiting for a vaccine before we can return to our homes in Florida?
I honestly don't see the border opening in any time soon, nor do I think it should. It's difficult, as Makeda mentioned at the beginning, difficult enough for us to contain our own existing infections that are still present in our communities, never mind trying to deal again with the input of infections coming from outside. And this origin of our epidemic, and probably why Quebec actually had such a bad epidemic compared to many other provinces in Canada, has very much to do with the fact that we have very strong and important ties with our neighbors to the south, in New York and in Florida. And that back and forth that we've always enjoyed so much led to, and an early March break here, led to multiple introductions probably of this virus unknowingly in the community before we had any clue that it was there. And that would happen again as soon as the border would be opened. And so it's very, you can look to, for example, New Zealand, which is a country which has managed, the only one in the world thus far, to actually probably eliminate COVID-19, at least in their community. They're now facing an influx of returning New Zealanders, and they have very strict quarantine. The government forces people into a 2-week quarantine in a government hotel. So it's, and they have, and relatively small numbers compared to what we would here. They've had tremendous difficulty even keeping individuals from those hotels not sneaking out and going to the grocery store. So you can see how this is just a huge challenge. Yeah.
So we want to leave our audience with a sense of hope. Makeda, I'm going to turn to you. What is your big dream for healthcare?
So, very genuine big dream. I mean, I chose to live in Montreal, and I chose Canada partly because of, I mean, Canada, I think, offers the universal health care that we're offered here, and particularly the type of medical care that's accessible at the MUHC. And I'm not just saying this because it's you, Julie, and or the foundation. I really think we have a really, really good thing going. We're able to offer innovation coupled with high quality in a good atmosphere in a country that's fair and equitable with universal healthcare coverage. What I'd really like to see is this model be reproduced elsewhere. I think we don't promote ourselves enough, or we don't promote this brand of MUHC/Canada, this brand of quality healthcare. I mean, I don't see it elsewhere, and it really would be worth transporting some of the lessons, some of what we do in places like, for example, so I've been talking about Ethiopia because that's where I'm from. You know, that would be my dream. That would be what I'd like to achieve, if possible, in some degree in my lifetime.
And Marina, over to you for the final words. What is your big dream?
Well, you know, one of the things I think COVID-19 has really taught us is how fast we can come together around a cause and make change. And how things that we thought never could be changed can be changed overnight. So just very basic examples. I mean, I'm working a lot with vulnerable communities in Montreal and across the country with Indigenous communities, with people who use drugs. And in order to prevent transmission, we suddenly could, you know, find homes for homeless people. It's possible. We have the capacity to do these things. We could provide safe drug supply to people using drugs so that they wouldn't be in a situation where they would have to put themselves at risk. We can do things very quickly when we set our minds to it, and the evidence is there. So what I would hope is really that we continue to bank the evidence to show that these policies really can make a difference, and then go that next step and actually implement them with the input of the people who are most affected. If we had listened to people in the CHSLD, to their patients that were there and to their caregivers at the very beginning, who were saying, don't kick us out, we're the only ones who can provide care, teach us how to give that care safely. If we had done that, we would be in a very different situation today in Quebec. And so I think we really have to have a system that really hears the voices of the people who are impacted most and integrate that into our health systems.
Well, Marina, you're being very humble because you're leading a group that is trying to completely abolish hepatitis C in Montreal and making this the first city in the world that has managed to do so. You talk about vulnerable communities. In fact, what I love about both of you is that's been your focus. How do you think we're going to achieve that, making Montreal Hep C free?
Well, you know, now that I wasn't working on COVID, last week I've been put together a big application to try to support that work. But it's a big challenge, but it's really building on those things that I was just saying, is really doing this led together with the communities and designing what I call co-designing interventions that meet their needs and at the same time meet the needs of getting people onto treatment and cured from hepatitis C. And we think that it's a model that COVID has really taught us is needed right now. And I think if we can develop this model, it will really serve to show how we can address all sorts of different health concerns for vulnerable communities, not just hepatitis C, which is something unfortunately can cure in a short time, but you know, other issues that they face.
Well, I want to thank you both very much for joining us today and for sharing your experience and what you've seen behind the scenes at the MUHC with the COVID-19 pandemic. So Dr. Marina Klein, Dr. Makeda Semret, thank you so much for joining us, and thank you to the audience for being with us today. And I hope you'll join us again on July 22nd when we are joined by Dr. Abhinav Sharma and Dr. Jerry Freed, and they will talk to us about how technology is disrupting healthcare.